Tēnā koutou katoa, ko Megan Grant tōku ingoa. E mahi ana o ki manatu hauora. Today I have great pleasure in introducing Professor Jim Mann to you. Jim is Director of the Healthier Lives National Science Challenge, the World Health Organisation Collaborating Centre for Human Nutrition, and the New Zealand-China Non-Communicable Diseases Research Collaboration Centre, and co-director of the Edgar Diabetes and Obesity Research Centre. He has been Professor in Medicine and Human Nutrition at the University of Otago and Consultant Physician in Endocrinology in Dunedin Hospital for the past 30 years. His research has principally been related to the epidemiological and nutritional aspects of diabetes and cardiovascular disease, with a special interest in diabetes prevention. I've known Jim for quite a few of those 30 years, by the way. Was reminiscing with him about when our children were very little some time ago. Today, Jim is going to introduce the Healthier Lives work and the 3 projects being shared with us today. 2 of these 3 featured projects today formed part of a 3-way partnership between the Ministry of Health, the HRC and the National Science Challenge, and I had the great pleasure in playing a small part in setting that up some years ago. So I'm handing over to Jim. Thank you very much. Please join me in welcoming Professor Jim Mann.
Kia ora koutou katoa. I'm going to jump straight in because we've got a lot to present to you in the next 70 minutes. And my task in the next 10 minutes is to introduce you to the Healthier Lives National Science Challenge. We were given our objective by the decision of Cabinet, so it's in the Gazette, so it's all terribly legal. And our objective, as you can see up here, was to reduce the burden of major New Zealand health problems. No problem, just that's all we had to do. The point I'd like to make right at the beginning is that every talk today, or pretty much every talk today, has addressed this issue in some form, shape, or size, but our specific role is a research role. So we are there to do research which will enable us to reach this objective. And we have somewhat rewritten the objective. Sorry, this is just to point out to you that although it is a more general statement, cancer, cardiovascular disease, diabetes, and obesity are the 4 core diseases which were identified. In fact, there was a lot of criticism initially. What about chronic respiratory disease? That's pretty important too. And we have fortunately been able to touch on some of the other non-communicable disease, long-term conditions, but these are the 4 that are actually written down in the Gazette. We have taken that objective and developed a vision for our science challenge, which states clearly that our vision is of a Aotearoa New Zealand with equitable health outcomes and a substantially reduced burden of non-communicable disease. So you can see that equity is absolutely up front in what we hope to try and achieve. We have got 3 themes to the Healthier Lives National Science Challenge. The first theme is aiming to do something about the environment, or doing research in relation to the environment in terms of food and physical activity, with a hope of reducing the population risk of these non-communicable diseases. Food and physical activity, because they are principal causes of these diseases, and of course smoking is important, but smoking is addressed in a number of other areas, so smoking is not our key priority for this purpose. And really, I was heartened by what John said earlier on today, because he made the point that we can't solve everything in a short period of time, and so to add in yet another important determinant of health would have been really very difficult, in fact impossible. The second theme is based around culturally centered health interventions for Māori and Pacific, with particular reference to whānau ora approaches, And the third one is around precision medicine and personalized prevention, that is to say, individually targeted approaches to reduce these non-communicable diseases. Now, we were given by government through MB, all the science challenges are function through MB. We were given 31 million over 10 years, which may sound like a lot, but if you think of what our objectives are and what our vision is, it's actually not a great deal of money. And I always like to remind people when they suggest that we should be doing more, that we have got the smallest level of funding of all the science challenges, including the two other health-related science challenges, which are to do with health in young people, called A Better Start, and health in the older population, which is called Aging Well. But we were very fortunate in that we were able to become part of the long-term conditions partnership with the Ministry of Health and the Health Research Council. And as Megan mentioned earlier on when she introduced this session, I would like to actually acknowledge Karen Everson, who many of you will know, who was really a mastermind in helping to develop this, although Megan played an important role, and representatives from the HRC played an important role too. And as you can see here, there are the kind of obvious things which this long-term conditions partnership aimed to achieve. Co-design has been mentioned several times today, and I always worry when I hear people talk about co-design, because I worry that many people who use that term don't actually know what co-design means. The term genuine co-design has been coined, and I mean, I sometimes wonder even if people know what genuine co-design means. But co-design for many people involves having a focus group with a couple of friendly individuals and moving along from there. Co-design is not, as I think everybody in this room knows, a one-off hui, one-off kororo, one-off fono. It is a true collaboration with a community involved, starting off with what the questions are and continuing through the entire research process up to and including implementation of the research. Phase one, which is completed in terms of time, though not in terms of all the projects that are involved, had 10 research projects, 5 core-funded, 5 funded by the partnership, and I'm not able to go into them in any great detail, although I'll mention one or two in a moment. But if you go to our website, which is very easy to find, there are also newsletters, research finding briefs, and some literature outside the door. You will get details of the 10 research projects that have been funded. I do just want to spend a couple of minutes talking about the research products which have emerged from phase one. I don't actually like that term, products, but it is a term that MB uses, and it's probably not a bad term really, because we are all about mission-led research. We want to achieve results, we want to make a difference to health, and so the products are outputs of the research which we hope will be implementable and implemented. And just to mention a couple of them very briefly, ethnic-specific risk prediction equations for cardiovascular disease. We heard a lot this morning about cardiovascular risk assessment. I'm sure some of you, if not all of you, know that the original risk prediction equations were based on 4,000 people in the United States. Goodness knows how many years ago. We now have risk prediction equations for cardiovascular risk, which are ethnic-specific and relevant to the New Zealand population. The Ola Ora application and website to support healthy lifestyles for Māori and Pacifica. Again, this was identified as a need from the populations concerned, and a particularly novel one, which is ctDNA blood testing, which we think has a potential for influencing in a very major way the way colorectal cancer and melanoma surveillance is undertaken. People will hopefully be spared traveling long distances to have scans by a simple blood test, which will also give an indication of successive treatment. No time to go into that in detail, but there's some details outside. I'm not going to say anything about the ones in blue, the Heipa Kinga Waiora implementation framework, or the interactive community map of Christchurch, because that is the topic of some presentations which are going to follow mine. There is some ongoing phase 1 research, details of which are also available, but just to mention the whanaora approach to long-term conditions, diabetes in particular, aimed at Māori and Pacific populations, which Rawiri is going to talk about, and several others which are continuing, not quite completed yet. Phase 2 research, there are a large number of projects which are involved in phase 2 research. The first 3 in dark print there are those which have already been approved for funding, signed off for funding. The longer list at the bottom are those which are currently being developed. I will just mention perhaps the access one, which again follows on from what was talked about this morning. We know what to do about a lot of cardiovascular and diabetes risk, but it's not actually taking place. So we heard about that this morning from ProCare, but this again is research-based in order to try and investigate these gaps in treatment for Māori and Pacific, and initiating research which will examine different approaches to reduce and hopefully ultimately eliminate these gaps. Our challenge is one that we've heard about repeatedly. The New Zealand health system is not delivering equitable outcomes. The Y report has been mentioned several times. And what we are really concerned, and particularly today to present what the challenge is doing to help change this, we are going to present a series of projects which are based on developing a model of trusted health navigators working within the community setting, and in particular utilizing whanaora approaches. The 3 projects which you're going to hear about shortly, Manatū, Kimiora, and Well-Connected New Zealand, I will introduce in a couple of minutes from now. The model, is it costly? Yes, it is. But it is the only way we think we are likely to move towards cost-effective and more equitable outcomes, which is really what we're all striving for. By some absolute miracle, the clock shows 0, which means that I've actually done it in 10 minutes. I think the first time ever that I've succeeded in achieving that. So now it's my pleasure to introduce Rawiri Jensen, whom I know is very, very well known to many, if not most people in this room. Rawiri is of Ngāti Hinarangi and Ngāti Raukaua descent. He is very well known, not only in Auckland, where he is a practicing general practitioner. He is particularly well known as the clinical director of the National Ora Coalition. And I don't want to steal your time, Rawiri, by talking about all the other wonderful things that you're doing. But I just want to say one thing. I'm absolutely... Sorry, you get another half a minute for this. But I also did want to say how much we admire the fact that you go beyond medicine, and the work that you are doing for housing in Auckland, I think also should be recognised. Kia ora. You just push that green one.
Kia ora tātou. Thanks, Jim. Ko taku mihi tuatahi ki te mana whenua. Ka tira ka mihi kia koutou I konei. Tēnā koutou katoa. I'm going to start with an apology. It's a bit unusual for me. Okay, it's very unusual for me. I'm not the L'Oreal 2018 Woman Scientist of the Year. I'm not Matere Harwood. And I apologise on her behalf. She can't be with you today. She's got family in hospital, and she's got a shoulder injury from Wakaama. So you haven't got Matere, sorry about it, you've got me. But I am here to talk about Manatū Diabetes, our program that we've been running from the National Hauora Coalition. I'm going to assume that you are all literate and can read this. If there's anybody visually impaired that needs me to read these out. Thank you. So, Manatū, our kaupapa Māori perspective, that so the National Hauora Coalition is a Māori-led PHO based in Auckland, and we have clinics across 5 different district health board areas. And we are interested in taking a mana whānau order approach to everything that we do. So no surprise if you know some of the work that we do when we get involved in this particular opportunity. We want to be mindful of treaty rights and Indigenous rights. So we take a rights-based approach to what we're doing. And we're interested in being informed by the evidence, and sometimes we're interested in creating new evidence. So Māori and Pacific have higher rates of type 2 diabetes and complications. The ethnic disparities are increasing. So our aim is to improve diabetes outcomes, reduce disparities in incidence, hospitalisation and mortality rates by transforming primary health care. If you start at the bottom, we want to be able to look through this from a patient lens and ensure that we are engaging with whānau so that they set the goals and that we are committed to travelling on the journey with them, for them, aligned with self-determination. If you think about it from the clinic point of view, we want to make sure that the right thing to do is the easy thing to do. We want to integrate our tools and our systems and our processes across all of our clinics and lift that up at a system level. Let me be clear, there will be Māori leadership, equity will be the focus, and we will address the wider determinants. The context in Aotearoa New Zealand today is that there are many challenges that are impacting Māori today. Let's just take a look at that. So in my clinic work, for instance, it is impossibly difficult to work with whānau to manage diabetes and its complications when they are living in emergency housing, week by week, having to shift from some scungy, dingy motel to another one, with many family members in a room, and no certainty. And that's one end of that spectrum, but at Papakura Marae, where I have the privilege of working with Matere, with other Māori clinicians and with Māori community health workers, we've been at the sharp end of that housing crisis in Auckland, with whānau living in cars, where we ask ourselves, how did we get to this point? Where whānau say to us, I'm doing okay, I'm living in a garage. So that housing crisis has really incredible impacts. But anyway, here we go. Papakura was the site for part of the Manatū program, working with the most vulnerable populations in Auckland. And for those in our program, housing was a significant issue. That we see during winter, the number of families that have to make a choice between feeding the family and heating the house. That's me. Oh, my Twitter handle is Rawiri MJ. I've got 800 followers. At least, could be more. Jim follows me. So in the population in our study, it showed that their experiences of racism in the system is more than we might find otherwise in the New Zealand Health Survey. And we have to ask the question about that intersectionality. So racism, disableism, fatism. And so many of the patients who are most vulnerable and are struggling will have personal experiences of racism. They will have whānau experiences of racism in the health system. So significant challenges. So in talking about manaaki, and you might go manaaki, so there's at least some people divide it up and say the origin of that word manaaki is to cajole and strengthen people's mana, that's a good thing to do. But we wanted to have explicitly a role that walks alongside the patient in their journey. And so Jim referred to it, I think, as being a program that kind of aligns with the idea of patient navigation, which is required because we built such a fucking complicated health system. I apologise for swearing, but it's in this Stanford study, Profanity and Honesty. You can look that one up. If I don't get one swear word in, you know I wasn't telling the truth. So yeah, our program is based in GP clinics, but it provides support for whānau in their lived realities, and it's aligned with community development. How am I doing on time? I'd like to introduce, all the way from Dargaville, via Tāmaki Makaurau, Tāria Tāne, who was the genius who ran the hub for Manatū Diabetes. Put your hands together. 3 minutes, 45 seconds, we're going well. As an aside, when Counties Manukau looked at doing a new version of their primary mental health services, the team at Papakura Marae took it and started having an authentic conversation about what wellness might look like for Papakura Marae, and they ended up writing up a list of about 15 things, and the clinical team received that, and we looked at it and we said, oh, Jesus, that's fantastic, that's brilliant, and we endorsed it, and I said, hang on a minute, just check. Yeah, totally endorsed it, and I said, right, because what the community said, they did not ask for any extended GP consults, they did not ask for any nurse consults, they did not ask for any consults at all. And if the community is in charge, they wouldn't be spending $1.4 billion on the health system, they would be investing in community development, just saying. Look, Hone did really well, all right? Just check that out. Look at that HbA1c, that's deadly. I can't explain why he wanted to watch the Warriors, it's beyond me. So at an individual level, lots of the whānau who were involved in the program had a really great experience, and then across the whole cohort you can see a really significant decrease in that HbA1c. Oh shit, no difference in the BP, sorry about that. Oops, made no difference in the lipids. That's okay though, that's still a good result, right? I could pause for effect and you put your hands together, that's a bloody good result, people. And their experience of being on the program demonstrated in these numbers, I think, is compelling. That's a good number, 84%. My clock's counting down. I've got one thing I want to tell you. I've got good news and bad news. The good news is I think we cracked it. The bad news is that you can't copy it. You need us. Earlier slide said you need Māori health leadership. And if we're going to get this job done, you must authentically engage with Māori leadership to get this job done. That's my key message. What you're lucky enough to have is that Tāria Tāne will be running a workshop in here later on this afternoon, and her genius about how to organise a hub so that this can run across multiple sites. That's our gift to you today. Kia ora tātou.
Kia ora Rawiri. Thank you. We'll have time for questions and discussions at the end. But now I'm going to introduce Dr. Nina Scott and Shay Simpson. Nina affiliates to Ngā Ngāti Whātua, and Waikato. She is public health physician, I'm going to say community physician, public health physician with Waikato DHB. But even more importantly, she's a PI with Healthier Lives. I have to say that. She has many tasks and responsibilities, but just to mention one, which I know occupies a great deal of Nina's time, is that she is chair of the He Ahuru Moai, the National Māori Cancer Leadership Group, which I know she plays a fantastic role in that particular aspect. Shay is going to be doing part of the talk, and she is affiliates with Ngāti Rongo Mai Wahine. She is a community researcher with Waikato DHB, and I know that she is a pivotal part of all the work that is being done by this group. So they're going to talk a bit about, in particular, I think, the Kimiora program, but we'll probably mention, I see that you are going to mention the He Pakinga Waiora framework, which has been developed as part of their Healthier Lives program of work.
Tēnā koutou, tēnā koutou, tēnā rā tātou katoa. So I think the HPW framework will be also useful for people to, when working alongside Māori leadership and doing true power and resource sharing in your journey towards equity, which it's very good to see that everybody's really keen on that nowadays. So we had a great team. I was one of 3 co-PIs along with John Etzel and Bridget Masters-Awatiri. The first thing we did was to develop an implementation science framework, and then we tested it with 2 communities, and Shay's going to talk about the results from one community site. First of all, why did we think we needed one of these? And there's about 5 posters out there, so but you can get them from the website. Firstly, it's a tool to overcome institutionalised racism. So inaction in the face of need is one of the fundamental causes of health inequities. And there are a lot of things that will work for Indigenous populations that are not being implemented, one, because they're not prioritised, but secondly, even if they are, it's quite hard to translate something from America to a Māori community. So you need to go through some sort of process to implement something from one population to another, or from a research setting to a real world setting. And that's what implementation science is all about. It's about methods to do that well. We also found that community engagement and co-design wasn't something that is well understood in health generally. So there was a need for something that would help guide people through that process. So the team developed this, it's all based on international best practice and informed, centred within a kaupapa Māori context. And John and Bridget are the 2 experts in that space. So cultural centeredness and community engagement, and I think probably a lot of you in the audience already know how to do this really well. And I did a master's in public health and a whole lot of diplomas and stuff, and it was a really nice reflection for me, and even though you know this stuff, it's quite good to have explicit guidelines on how to do it, because you're like, oh yeah, okay, that's what I haven't been doing very well. Especially around structural resources. John reckons that you should give 50% of your research budget to the community to decide how to spend. And I'm like, okay, that's kind of interesting. And I don't know if many people actually do that. And getting the people who will be delivering the intervention involved right from the start in designing the intervention and testing it and evaluating it. And integrated knowledge translation, the people who will be funding it in the future need to help posit the research questions that your proposal, that anything you're going to do is going to answer. So it was a nice reminder on how to do things. So I learnt a lot, having to give webinars and seminars and stuff on this. I was like, oh, okay. Systems thinking is something as a public health physician I think is very intuitive, but I find that a lot of my colleagues aren't intuitively into this kind of stuff. So it's about thinking big picture and thinking colonisation and racism and sharing power and having a treaty-based approach. And getting all these people around the table who have multiple perspectives, and not just getting all the people around the table who you get along with and who think like you, because that just doesn't work. So we had, goodness me, how do I do this? Oh, there we go. So we, a quick look at the literature will show that lifestyle modification works for diabetes prevention. That was our topic. So pre-diabetes to diabetes, the prevention of that in that space. Even small weight reduction works, and the international model is for Indigenous people is a special diabetes program for Indians, and it works, but the challenge is very, very low retention. So we thought we'd go down that track and co-design something that would work. We have a website and an evaluation tools. So Te Koha was a neighbourhood setting, and Potiri was a rural setting, working with gang whānau, predominantly men. So Ole showed us that New Zealand Inc. is getting worse with both preventing and managing diabetes. And Manatū included addressing clinical inertia as part of their approach. And just from having chats with Mātiri, I think that was one of the most challenging things, was getting GPs to stop doing that. So our approach started with a really strong interest in primary care, but our continuous co-design journey took us into a completely unexpected space. I had no idea that this was going to happen. And in the spirit of true co-design and power sharing, I'm handing the rest of the presentation over to the community partner.
Tēnā koutou katoa, ko Shay Simpson tōku ingoa. I was formerly a community researcher with Te Koha Health, but I've just recently jumped the fence and gone to Waikato DHB, so that's terrible. But so picking up on what Nina's been was explaining about the He Picking a Wilder framework, where we jumped in as a community research partner. For those of you who may be familiar with Te Koha Health, the provider based in Hamilton, they're a marae-based provider to predominantly urban Māori. It's 90% Māori population, a lot of services that they deliver. Whānau ora, they have a clinic, they have education and social services as well. In terms of partnered community co-design, we chose to look at the community of Melville, which is about a deprivation 25% Māori population area, quite a lot of need and quite an area in flux, like a lot of New Zealand places at the moment. A lot of it's a community in change. These houses are now much more expensive. It was an area of a lot of state homes and places where intergenerational families had been for years, but it's now one of those communities where it's like the last few with a quarter-acre section, and people that are trying to get first houses in there, which has just created a flux of change and need in these areas, but it's probably not unique to that space. So talking about Kimi ora, when we went to translate what He Picking a Wilder was, I think building on the concept of co-design, the greatest thing and the greatest opportunity that co-design gave to this project, and particularly to Te Koha and us, was the capacity and capability building to create something from a kaupapa Māori point of view within a Māori provider, but with the research and the capacity that's supported by amazing people, as in researchers from the University of Waikato, Nina Scott, and all the different things that meant we could go and experiment and try something, but have the safety of being all this expertise to actually lead it out and do it well. So it had a multi-level whānau focus, individual and whānau focus. So we looked at individuals, whānaus, community wellness, systems, intersectional and primary care, and it was very comprehensive. So the process of how we did this is we took the American program, we took the He Piki Waiata framework, we took the first stages of co-design, and we went to the community, the whānau that we're working with in Melville, and we talked to them and we said, what does this look like for you? What do you want from this? I mean, we know what the state of healthcare is for Māori. We know what we want to achieve. We want better health and those types of things. But what do you want? And they said to us, yeah, we want better health. But we want better health not just for ourselves, but for our whole whānau. And we want connectedness. And we want things like knowing the people in our community. And we want safety. Those are the things that are important to us. So the way that you do this, yes, have the clinical stuff because we need it. We do. But we want these extra things as well. So that's what we did. Part of our program was a whole whānau education program. We worked with 35 whānau during the research part, and we had a Māori clinical exercise physiologist leading that, who worked alongside whānau in a similar way to Manatū did. And of course, our whānau that were working through this were also supported by whānau ora. But the additional thing that this gave was some specialist kind of education and support and awhi around the particular disease and what they needed to do nutrition-wise within their means, so kai that they could afford, kai that they could easily access in their community, things that they could do for themselves, just access to things that would help them be healthy within their own streets. So in the research phase, we had 35 whānau. It's now been expanded and funded by Waikato District Health Board to continue, and we've been working with 110 whānau. Our numbers are pretty great. We're pretty excited. 4.5% weight loss, 12% reduction in HbA1c. But the most important one is 100% retention, because that means that they liked it. And that's because the co-creation and capacity building that happened meant that they owned it. And when we were doing things that they didn't like, they felt empowered to say, I don't really like that. So there was a time, I won't call it an incident, it's a whole whānau thing, so they had children and they'd bring their kids and talk about it, and the question came up that said, hey, do you want to include BMI for your children? And they said, no. Why would you do that? You don't measure our kids, we don't need you to do that. And we said, oh, we thought it'd be a good idea, but it's not. Okay, we won't do it. So very much a shared process. And from a community perspective, so the dual focus was on the safety and those types of things and engagement that people wanted, connectivity. So the whole group, the whānau group that we worked with, ran community engagement hui and managed to attract 200 whānau into a community kai, just to sit around and talk and be connected to services in the area and meet people. Local businesses sponsored it. Waikato DHB brought health services, other people brought health services, and it was a really nice night for the community. The groups have done things like plant fruit trees in their own streets. They look after the fruit trees, and those kids are really looking forward to. They're a part of those journeys, and they're telling us and a part of creating it for themselves. Time's up, and no. I think there's a thing that always says it's by Māori for Māori. So I would say as well with Māori. So our lovely CEP clinical exercise physiologist couldn't be here today, so I'm filling her shoes. She's busy having a baby, which is quite important. But she walked alongside whānau through this journey as well, through her own health journey. So she'd had health issues. She's the same. She's a mother of soon to be 5, but walked alongside them, did the same things, encouraged them, and through her own process, lost 25 kilos through the research program. So I think it's powerful in that we aren't talking to you or telling you, we're doing with you, alongside you, empowering. And for us, co-design never stopped. Co-design was not a thing that happened in the beginning, it was all the way through. Kia ora. And I think the last one is Nina.
Kia ora, Shay. So I have some publications. I think that's our first one, and that's the link to our website where you can get a whole lot of just guides on how to do co-design. And one of our publications was looking at. So we started. It was supposed to be diabetes prevention, and it kind of morphed into managing people, supporting people with diabetes and diabetes prevention, and And basically the community threw out all our eligibility criteria. It started off with a real kind of power sharing, and they'd come and say, oh, can we just slightly adjust the eligibility to say, as well as pre-diabetes, people with diabetes? And we'd go away and we'd have a meeting and we'd go, oh, okay. And then they were like, oh, what about can we add obesity? And we're like, oh, okay, it's getting a bit stretchy, but all right. And then eventually, like a month later, they'd say, oh, yeah, no, we've changed the eligibility criteria quite a lot. You don't actually have to have anything. You can have whānau members with something, or basically there are no eligibility criteria. But one of the ones that was looking at, this is mostly NHC, so you guys should have talked about this, but I'll do it for you. And you can have a free poster. So this is with the IDI group, with Andrea Ting, looking at what are the determinants of progress from pre-diabetes to diabetes, and what determines, what are protective factors along that journey. And we thought we'd just chuck Te Reo Māori in there because it would be interesting, and it turned out it was a really strong protective factor, so that was cool. And supporting Te Reo Meona Tikanga, which is, I think, as well as equity, we have those rights sit alongside, and one doesn't need to justify the other. So kia ora.
Kia ora, Nina and Shay. I'm glad you mentioned that at the last minute, because I was going to mention that and I didn't have time in my presentation. But I think that finding that being fluent or speaking te reo actually influenced prediction of progression from pre-diabetes to diabetes was a really fascinating finding, suggesting that connectivity with tikanga Māori and is an important determinant of this condition. And you try to look, I think, or try to look in that proposal at confounding factors, and while there were probably factors that couldn't be identified, the mere fact that this group of people actually had a lower rate of progression is an incredibly important finding. So talking about connectivity is a good way for me to introduce Mike Epton, who is a respiratory physician from Christchurch, director of the Canterbury Respiratory Research Group. And Mike has had a long-standing interest in the relationship between where people live and their health, particularly, I think, with environmental pollution and so on, but in general too. And he is the PI of Well Connected New Zealand, a somewhat different project from the two you've heard about now, but another one of the projects that was part of the long-term conditions partnership with the three organisations. So thank you very much for coming along, Mike.
Thank you all. From my accent, you'll very quickly determine that I'm originally English, I'm white, I'm elderly. I come from a privileged background. I come from a background in landowning in the east coast of Great Britain, farming, flat, no mountains, one river. It floods quite regularly and usually floods the brewery that's next door, so it's quite important. What I'd like to do is I'd like to talk through with you the journey that I have gone through as essentially, I'll call myself a conventional researcher and a conventional hospital physician. The journey that I've gone through and the team have gone through, and hopefully a number of you have gone through, in terms of how co-design and co-creation and the various other processes that you've already heard about have led us to what we call Well-Connected New Zealand. Te ranga I te tira, the weaving together of the people. And it was originally called, rather wordily, Improving Individuals, and the apostrophe is in the right place, Health by Strengthening Community Connectedness. Now this came about because we were frustrated with the settings of our current rehabilitation services. That essentially you've got a situation where people with one long-term condition, let's say lung disease, often have many others. So diabetes, heart disease, osteoporosis, anxiety, depression. And all of our rehabilitation programs have been predominantly set up by specialists in specialist environments, and they are disease-specific and they are siloed. And because of that, and a whole load of other reasons, essentially the attendance and the referral to all of these rehabilitation services is poor. So from a perspective of a respiratory physician, only 1% of the people who would actually get benefit from a rehabilitation service in respiratory disease are actually referred, and only between a third and half of those actually attend. And there's a whole load of reasons for this, but actually probably a lot of the rehabilitation processes are focused on medical models, and they don't address other aspects, particularly the biopsychosocial aspects. And of course, in fact, everything we do in health has relied on health professionals to access. We talked about this a little bit earlier. And I would point out to you Jeff Bezos, who is, of course, the CEO of Amazon, who says, even well-intentioned gatekeepers stifle innovation. And I think this is something we should remember. Even well-intentioned gatekeepers stifle innovation. And so we started thinking about system change and wondering how this might look. And what we wanted to do was move away from a medical model to a community and biopsychosocial model. And we wanted to start working with our local communities to strengthen local connectedness. Our original plan was to identify local social networks and identify them and use them to sort of seed health messages, that health basically was going to be a secondary gain out of social connectedness. And as part of that, the government and the funders asked us to think about appropriate technology, not only to support these initiatives, but to assess them. And I won't actually go into great detail of all of the findings because there's a lot on the website, so www.wellconnectednz.org. I will give you a link to that in a minute. And so this is not all of the answers, but essentially what we did was a participatory action research project, and it's a co-creator project. We wanted to find out what was already there and what communities actually want, rather than parachuting rehabilitation services into people. We set up a whole load of coffee and chat focus groups, and essentially, even though I'm a complete naive when it comes to co-creator, this was a co-creator process, and it was very clearly that. And so we were developing a model with our communities rather than parachuting one in. And very clearly, again, as a white English privileged person, we decided this was going to be very strongly underpinned by Māori healthcare models because this was appropriate, and by kaupapa Māori research methodology. And actually, really very early on, we started getting some very interesting conversations, and this, as it always does, changed the direction of where we wanted to go. And actually, one of the things that was very clear to us in our conversations about community connectedness and the things that might be able to be done to make things better was that actually many of the barriers are being put up by us as healthcare workers. That we are the ones who are putting in the barriers because we are predominantly safety conscious, we are risk averse, and part of it is the way that we're trained, part of it is our personality. But essentially, when we were talking about community connectedness and how things might work, the healthcare workers were going, well, if you're going to get that person to visit that person, what about the police checks? Do you have to have those for every community connection? And the same hui and the same discussions, one of the community people turned to my healthcare worker colleague and said, our communities don't need your permission to do things. And that was a very powerful message very, very early on in this. Our communities do not need your permission to do things. One of the other very clear messages that came out very early on, and I'll talk about this in a bit more detail in a minute, is that actually technology was not seen as the answer here. And there was a very early phrase, technology is cold. And what do you want? We don't want robots to help us be healthy. We want dogs to walk with to help us be healthy. And the other thing that came very clear is actually we thought post-earthquake in Christchurch there was a huge sort of gap in terms of services and community activities. But actually there was huge quantities going on. But we as healthcare workers and navigators did not know anything about them. So there was no way of finding out what was going on in our communities. One of the things that also became very, very clear out of this discussion is that we're actually using the wrong languages. That actually our current language of healthcare is very much deficit model based. And some of you are more aware of this than I am. But essentially, if you think about how we think in terms of health, it's very individualized and it's very deficit model. You have needs, we provide care. And this is kind of encapsulated in this whole concept that we see in respiratory outpatients, the did not attend. That's such a negative concept here. Actually, probably didn't attend because I wasn't giving the right messages and providing the right environment for you to feel wanted and to feel that you needed me. Giving as well as receiving was a very, very important part of this community discussion that we had, that actually a lot of our communities did not want to be seen as the recipients of health. They wanted to be seen as people who could contribute to their communities, and actually the way that we work often disenfranchises that. Young and old helping each other, that it's about basically not just elderly people with long-term conditions receiving stuff, it's actually contributing to their community. And what was very, very interesting, one of the team members was a writer. Her PhD that she is just about to submit is in the language of stillbirth, and it's a very powerful PhD. But actually having a writer on the team to actually say, do you realize the kind of language that you are using when you're discussing these issues? Do you realize what these words actually mean? And what is all this deficit model language that you're talking? And we as healthcare workers don't do that very well, and having a writer on the team was very eye-opening for me. The other thing that was very eye-opening, I do not speak Te Reo, and I apologize for that, but I don't. But what was very interesting is that Te Reo captures community concepts in words, whereas English language captures all of these concepts in phrases. And so what was fascinating is that actually Te Reo captures all of these concepts far better than English. And this has been very much a learning process for me. Now, if you have QR codes on your phones, now is the time to try and go to the Well-Connected website. But essentially, the Well-Connected website has this interactive map because people said, we don't know what's going on in our communities. So we worked with our geography colleagues in the University of Canterbury, and we basically sucked in all of the community resources that we could find from the council resources, Sport Canterbury, anything that might have relationship to community was all sucked in and is now available on a Google Maps platform. And so essentially, if you go to the Well-Connected website, you can see that there is an interactive map which is searchable not only by activity, but it's searchable by suburb and where you live. And so this is triggering conversations about what might be going on here. None of this is health-related. We deliberately did not put health activities on here. This is all community-related. And there's, giant hamster appreciation societies and that kind of stuff. There's all sorts of weird and random things on here. And I would encourage you to go and have a look on the website. I'm not live at the moment, but essentially what you can then do is you can say to your community, you can say, actually, there's stuff going on around you. Would you like to go down there? And by the way, you might want to walk because it's a little bit of activity for you. I'm just going to very briefly talk about technology, and in particular, my concerns that technology, if used wrongly, is going to increase inequity. And we came from this in terms of one of the comments we got from one of our Pacifica phonos that says, our language is not rich enough to use these phones. And that was a very interesting comment. And I put it to you here, I've got two maps. This is, my geography colleagues. The first map on here, this is access to smartphones and access to the internet where red is bad. So in other words, you've got very marked variation in terms of access to smartphones and access to the internet in Christchurch, and certainly eastern suburbs have down to 13% access. And interestingly, if you look at admission rates with COPD, the smoking-related disease, in Christchurch to Christchurch Hospital, you can see actually the maps mirror each other. So you've got this situation where access to technology and access to healthcare are kind of mirroring each other. And if you're not careful, if you put technology in an indiscriminate way, the people who live here and here are going to be the ones who are going to miss out. And we saw this particularly when we were working with a bunch of people with COPD. And interestingly, smartphones actually behave differently when you've got COPD. And this is bizarre, because we set up a whole load of technology for people to support people with COPD, and as soon as the patients got these things, their phones stopped working. And we started looking into this in a bit more detail, and it's very, very interesting, because actually, smartphones are designed by young engineering geeks and used by people like us, but not used by people with COPD. And so what I think is happening here is that these things are designed to be interacted with. Sorry, I've lost my slide. These things are designed to be interacted with, but if someone with COPD doesn't actually interact with it, we believe that the battery-saving technology inside of this is turning off many of the functions that we require to remind patients to do this, that, and the other, or to make technology work for our patients. If the phone turns off because it's not being interacted with, because of a battery-saving thing, then that actually increases inequity. It works for us, it does not work for our patients. Very interesting. I thought so anyway. We have learnt a lot. I'm not going to be able to cover all of this, but as an Englishman, as a privileged white person, I've learnt a lot. First, really listen to your community voices, all right? Because parachuting stuff in, from my perspective, is not the right way to go, but you've heard this already. Seeking solutions, not barriers. There are many, many people around, particularly in health, who will seek barriers to activities, and actually our communities are very good at seeking solutions. Identify deficit model speech and thought. Find champions. They do not have to be healthcare champions. And we've heard a little bit more about one of our colleagues in Pegasus who is identifying partnership care workers, PCWs. Identifying champions and navigators, really powerful. Breaking down silos and linking people, not just as a respiratory physician. Using technology to support rather than replace, and understand that if you indiscriminately use technology, you will potentially increase inequity. And what's been very clear here, and you know, you don't need me to say this, what works for Maori works for everybody. And we see this in something that was not from the Well Connected project, but Deborah should be very proud of this over here, because she set up a new rehab program at a local marae. Now remember, our previous rehab programs have completion rates of between 30 and 50%, but by working through a co-creator model at our local marae, we had greater than 100% completion at a recent pulmonary rehab program. More people finished it than started it. Now that is what I call success. I'm going to share my happy place. This is now my mountain. And if you think how cold that glider is, it's actually minus 30 in that cockpit. So it is a sort of happy place. And I'm happy to take any questions or any thoughts that you might have. Kia ora.
Well, thank you to everybody who's spoken. And it's amazing. We've actually stuck 100% to our timing. So we've really got 15 whole minutes for questions without getting into problems with Megan. So if everybody could you come up, and I think if we all sit around here and just take questions while people are coming up. I love that quote, even well-intended gatekeepers stifle intervention. I'm going to take, stifle innovation, rather. I'm going to take that back to my DHB, my university, my master's in every respect, because it's very true. There were lots of other truisms which came out in this conversation from all three presentations, but I'm not going to say any more, but invite questions. So have we got a second mic so that we can have one mic here and one roaming, or is that too much to... maybe we can't. Have we got a second? Can we have one mic here so that we can, and then one mic roaming around to yeah, so I'll just hand that to you, Robert. Right, questions or comments or whatever. I mean, I hope that you can see what we try to achieve, which is really to show you what Healthier Lives was doing in terms of research to answer some of these key issues.
I'd just like to thank Taylor, Alexandra, Lisa, Ernest for following. Thank you.
Yeah, so there's lots of stuff going out there.
And
so,
the photos of me look really good. Thank you.
Yeah.
Good quotes. Well done. Quote some of these other guys as well.
So have we given you all the answers that you need to go to take out from here? Can't believe that. Yeah, Ollie.
Thanks for everyone. It was really exciting, the different ideas. Took a lot of stuff away. Can I ask one to Raviri Jensen? What do you think is the reason for the minimal clinical outcome? Because I was looking for the outcomes. I've seen the data today for the first time. and I would have expected more clinical outcome. Not to say that they are all important, that other things what you presented probably equally or more important, but what's the reason for the minimal changes clinically?
I thought the HbA1c was compelling. Jim, what do you think? The HbA1c, that was good, right?
Well, HbA1c came to, but I think from the
defensive mode here. But, the blood pressure didn't change, the lipids didn't change, that's just true. We should tell the truth. But that HbA1c, that was good.
Well, I think the HbA1c is significant, and there are lots of studies, I might say, Ollie, as you know, which haven't shown a great deal more difference than that in HbA1c. But, I mean, having seen some of the data, which I've seen thanks to Martira, there's an enormous variation in response. So that was the mean that you saw. In fact, if you delve into those data, and Raviri, you can correct me if I'm wrong, there are some people that had dramatic improvements, and admittedly there are some people that didn't improve at all, which is inevitable. I think that what Raviri presented was a very quick first look at the data, and further look at the data I think will actually show a lot more. The other thing that is really interesting that we have discovered in other studies is that, and you got a little bit of that from the Kimiura data, is that a very small change in waist circumference can actually make quite a big difference in a range of metabolic outcomes, as you know, Ollie. And I think there's some aspects of these data which will show a lot more when one delves into them. It's a very preliminary look, correct?
What he said. And we're getting ready to publish Tadia, we're getting ready to publish. What's our expectation there? Couple of months. So we'll get more detail out to you, and I think then you'll be able to kind of unpack it and excoriate it further.
Chris.
Kia ora, thank you for those presentations. I've really enjoyed the conversation about community rehabilitation and the value that offers, and I'm interested in your perspectives, certainly as a respiratory physician, around a focus on pulmonary rehabilitation only, but the community is demanding more of a holistic, and so the value of the openness of just long-term condition rehabilitation, and whether we look even further to sort of better funding of community-wide long-term rehabilitation, long-term condition community rehabilitation, whether it's run out of maraes or church halls or whatever else, and whether that would be a good vision for the future.
How do I turn this on? Is that on? Yeah. I think one of the problems that we're going to face is if we continue to call it rehabilitation, then we're probably going to fail. And certainly, yes, as physicians, we want to see rehabilitation activities going on. But if we label it like that, and even if we label it like long-term conditions as opposed to disease-specific, then we potentially may fail. Now, I think moving away from disease-specific rehabilitation to long-term condition-type rehabilitation is probably one start. But actually, at the end of the day, I believe that as a community, if we can encourage more activity and that we can drop in education and support, then that may be a better model. And certainly it's more acceptable to our communities than essentially having a very medical model, whether you call it long-term conditions focused or disease focused. I personally am heading much further away from it, that you actually encourage your community to become more active and that you drop in health messages. I've tended to, the analogy I've used is that our approach to this is a bit like the Somme. So you come out, you go out of your trenches and you march across to our communities and you deliver healthcare. Whereas actually probably as a community, as a healthcare community, we probably need to work a bit more like the Viet Cong. So sneaking into communities, joining in with their activities and dropping our ideas in at the same time. But that's a vision.
Okay. Righto. I think that's the Kimiura program essentially did what you suggest there. So we, with our little doctor hats on, we came in doing a rehab program, or a diabetes prevention program. And you, Shay, you had people with depression, arthritis, grandparents who were fine, but their mokos weren't. And so it just, because it was actual proper co-design, and we lost the power to control it, which is the ultimate goal, right? Then it developed into something that the community wanted, and that's what they came up with.
That's how
And that is what worked. So we got more than 100% retention too, just saying.
Yeah.
So, and I was really annoyed that they wouldn't let us measure the kids at the start, because, you know, I'm sure it had an impact. I'm sure if we had been able to do BMI and stuff on the kids or exercise, that it would have made an impact. But, you know, that's what happens when you lose power. Beautiful things happen.
Yeah.
Yeah, do you want to add anything to that? No, that's good what you said.
Other comments or questions? It's late in the day, but this is your chance to, and of course there are workshops after this. Perhaps just as we got another few minutes, don't really want to say too much in terms of summing up, because it's really very hard to sum up what you've heard now. But I do just want to pick up what Ollie said, because I think it is really important. I mean, we heard this morning about ProCare. We heard about some initiatives which are being introduced into ProCare, which are really exciting. They're really good. But, I mean, what the science challenges are trying to do, and this particular science challenge in this instance, is to really try and provide you, as people from the DHB, people from PHOs, people from the ministry, who are going to make decisions about what to put into healthcare practice with evidence-based answers as to what is really going to work. Now, I mean, one of the things that is equally clear to you is when you work in this space, research is not easy and straightforward. When you land up with more people than you start with, you know, my background, my PhD was actually in biochemistry. So you can imagine it was pretty difficult for me to start to grapple with the kind of work that you've heard presented today. But actually, this is the important stuff. And I think you have heard today about three projects which Well-Connected New Zealand is different from the other two that you heard about. But they all, of course, refer to this concept of navigation of the health system. This is very hard research to do in terms of standard research methodology. But it is actually possible. And we are going to get some tremendous insights into what works and what doesn't work. And I think, Ollie, I mean, it would be really interesting to keep you followed up, and maybe at the workshop you might be going to hear some more stuff which will help you to interpret those data, so perhaps you should go to the Mana 2 workshop and have further discussion there. But as I said earlier on, by delving into the data, I think you are going to get further insights. We need to know why some of those people that Rawari spoke about did phenomenally well, why some people had a dramatic reduction in hemoglobin A1C, and it's not just that one patient, is it? I mean, there are a lot of people who did well, and I think the study is big enough, and it is very hard to do controlled studies in this situation, but these are as controlled as they're ever going to be in the community context. So I think they will actually be able to tell the ministry, DHBs and PHOs which aspect should really form part of primary care, secondary care in New Zealand. They will inform that. And so we will be able to move away what seems to be like a good idea. I think we can be pretty confident that navigators or navigation as well as navigators are absolutely pivotal in our health system as we know it today. And when you hear things, I mean, Mike talked about our language that we use is shocking. The number of times I, as an endocrinologist physician, talked about DNAs, you know, these 50 people DNA'd today, and, you know, time was wasted. This is kind of stuff that we've got to move on from. And I think research like we've heard today has been absolutely pivotal in moving in this direction. So there's still another 3 minutes if anybody's got burning questions. But otherwise, was there a burning question somewhere? No, everybody's absolutely exhausted. Somebody's got their hand.
Rawari might have
Rawari wants to say something.
A burning answer.
I'll tell you a story. When I was a house surgeon, I was at Manukau Super Duper Clinic, and I was doing ear, nose and throat. And at the end of the second week, they brought me this whole pile of things and said, oh, you have to sort out all of these, who gets a referral, who doesn't get a referral. Oh, fucking hell, what do I do with that? And they said, oh, well, you got to decide, these are the people who have missed appointment, and you got to make a decision about who gets another appointment. I said, oh, well, that's easy. All the Māoris get another appointment, and all the Pākehās, they had their chance. And there was this nurse, and she blew up. Oh, you can't do that. That's racist. That's racist. You can't do that. That's shocking. And they said, actually, the rules are, if they've missed 2 and now they've missed a 3rd, then you discharge them. And if they've missed less than that, then you give them another appointment. So, fuck, you don't need me for that, if that's the rules. But after that, a woman came up to me, and she was a support worker, and she had overheard that, and she said, you give me all of those Māori patients who have missed and are going to be discharged, and I'll find them. And she knew how to do that. In fact, as a result of that, she wanted to come up with an idea that said, they looked for an innovation plan at Super Duper Clinic or something. She wanted a van. She would be able to go out there and engage with, and she knew that actually to get this family, you had to ring this auntie and say, Auntie, can you go up the road and ask them? Right, so that kind of connections, which, okay, it doesn't quite fit with our Privacy Act, but man, she could get this job done. So, and then the other guy was talking about, I don't know, whatever your question was, but it made me think, in my fantasy, we would make sure that we are strengthening all of those community organisations. That was the great hamster, whatever his thing was. So that was Christchurch. But you imagine the rich diagram that Papakura should be, and that we have a chess club, and we have a wakaama club, and we have kapahaka club, and we have all of those things going, and they're supported. Because at the moment, the health system is dragging billions of dollars, and communities are struggling. We got that wrong. We need to change it. So if that organisation, Procare, you're up for it, start sponsoring some stuff in communities so that the Wakaama Club is really sponsored and they're doing well, and the Chess Club is getting some funding, so that when we've got people and we need to join them up and we need to support them becoming connected, those organisations are funded, they're happy, they're really thriving. We've got to make our communities thrive, and then everybody in it is being loved and supported. We've got to support our communities. Give it up. Now I'd like you all to go to your workshops. There's 2 workshops. One is in here and one is somewhere else. Now don't muck around. I want you to get there really fast, take 2-3 minutes, all right? Anything else, Megan?
I just wanted to thank everybody.
Oh, and thanks, everybody.
Thank you, panel. That was fantastic. Thank you.
Brilliant.